Should we? All right. Good afternoon, everyone. I hope you all are all ready for a wonderful session on family planning and its integration with maternal child health services. I'm Dr. Priya Karna, Technical Officer for Reproductive Health at the WHO Country Office for India. And I will be joined by an esteemed set of presenters who will be presenting their scientific papers. As I call upon my very esteemed colleagues, please do come and join me on the stage. In that, and I will be introducing each presenter, and you can then come to the stage, and the floor is yours. Each presenter has a maximum of 15 minutes, and after each presentation, we'll keep the floor open for about 5 minutes for questions from the audience. So with that, I'd like to invite Yingyi, Dr. Rajiv, Mr. Heather, and Dr. Mahesh to please join me on the stage. We'll start with our first presentation for the day, for this session at ICFP. The presentation is going to be, oh, did you want? No. Okay, so the first presentation for this session is going to be by Yingyi. Yingyi is a PhD candidate at the University of Southern California, studying population health, spatial sciences, and social demography. Her doctoral dissertation examines the child health consequences of family planning policies and programs in sub-Saharan Africa and China. She is interested in understanding the intersecting role of contextual, familial, and individual forces patterning child health and well-being. And today, she will be presenting on the spillover of modern contraceptive diffusion on under 5 nutrition, an analysis of 29 lower middle income countries from sub-Saharan Africa from the time period 1991 to 2020. Over to you, Yingyi.
Thank you so much.
Good luck.
Thank you so much for the introduction. The title is slightly different, but the content that I'm presenting today is pretty much the same. So I'm just going to do this. So thank you so much for coming. Again, my name is Yingyi. I'm a PhD candidate at University of Southern California. And I start by the motivation of this research I'm presenting today. So the part of my dissertation, aka this research, is really motivated by the fact that we know a lot about the benefits of family planning. We know a lot about the benefits of family planning for maternal and child health for women who have access to and obtain contraception, right? And for my research, I really want to look beyond these individual level benefits of family planning on child health to really consider the salience of contraceptive context. By context, I mean we know less about the fact that children are growing up in very diverse contexts, places where women have a diversity of access to family planning information and services. And just by attending this conference, I get to know this new terminology called contraceptive transition, wherein this population level of contraceptive uptake transition from low to high level. That means in some places, children are surrounded by women virtually. No women have any means to control for their fertility, whereas in other places, a high proportion of women having the means to manage their fertility. And we don't know, what we don't really know is the child health consequences of this swift expansion of contraceptive access, especially across low and middle income countries. And in this paper, basically, I want to understand this idea of spillover of contraception to look at the meaning of contraception at a population level, even for children whose mother have no access to contraception. So when we talk about the population level meaning of contraception, we often think of it linking to fertility decline. That is, for individual families who have access to family planning, they likely have a smaller family size, widely spaced birth, and these kind of individual level fertility decline could eventually aggregate at a societal level, like leading to these like smaller cohorts and hence theoretically increase societal resources allocated per child, which lead to better child health outcomes. This fertility decline or fertility spillover channel is well established in especially highly industrialized settings, and even now more recently in middle income countries, but less so in low income countries, especially sub-Saharan Africa, wherein fertility stall is not uncommon. So based on that context, the little salience of fertility decline in this continent, I really want to ask this question of examining the meaning of contraception beyond fertility decline to theorize that contraception as this behavior denoting a distinct dimension of women empowerment. Like, for instance, contraception is this clear indicator of women's ability to control for their fertility. And I theorize that this level of ability to control fertility might also translate to women's ability to control other resources like household resources, even more broadly, societal resources. So in comparison, I'm not saying that fertility decline is not salient, but I somewhat questioning this like theory, quote unquote, high fertility equals to less resources. But I think what matters more is not these like theoretically, mathematically calculated resources, but in reality, what matters more is how much of these resources can be controlled by women, especially considering women pertains to the most intimate social and biological relationship with children, and women are the main caregiver for children. All that being said, in this paper, I want to ask this one research question: do children benefit from living in a place with higher population uptake of contraception, regardless of their mother's own use of contraception? That is, even for children whose mother have no access to contraception, do they benefit from living around many other contraceptive women? And to answer this research question, I leveraged demographic health surveys. Many of you know that it's a primary source of family planning and population health data in low and middle income countries, and HDHS surveys sample these nationally representative women sample of reproductive age and their children. In this paper, I look into a sample of over 90,000 under 5 children living across 29 sub-Saharan African countries. This map here is the included countries for this study. There are 2 key study measures I'm looking at here. First of all is to account for these individual level benefits of having access to contraception, the maternal uptake of contraception. I use this study measure asking whether mother have ever used any contraception, which is a direct question probed in DHS. And above and beyond this individual level access to contraception, I look beyond to look at this contraceptive context. Basically, I combine multi-country data to leverage the substantial variation in contraceptive preference across 292 subnational regions, ranging from 3% to 88%, which is very wide range, over 80% differences. In this figure, I want to show you again the substantial spatial variation in terms of contraceptive access women have. Each dot here represents one subnational region within each country. So I plot the prevalence of women who have ever used any contraception in just this past decade. And I plot this regional preference by each country. And here in this figure, I really want to emphasize that the spatial variation in contraceptive access is not only substantial across countries, but even within countries across regions. And to understand the child health consequences of living in such diverse contexts, I focus on child wasting, a most recent nutrition indicator. More importantly, it net out of this population heterogeneity due to genetic factors, that is, net of height. And in understanding the contraceptive benefits at both individual level and this contextual level, aka the spillover, I fit a set of multi-level logistic regression models with a rich set of child level, parent, household level, and importantly, regional level controls. Things like average women's education in that region and fertility level, mortality level, disease prevalence, a lot of these confounding factors that could spuriously drive any association between contraceptive preference, my key study variable, and child nutrition. I lastly also control for these like country year dummies, the so-called FX effect to account for these unobserved, unmeasurable confounding factors across by places in time. So in the study result, I just want to show you these one key models of my final results. So first of all, I want to highlight that I did confirm what other people find the individual level benefits of having access to contraception. That is, children's odds of wasting is at least 8% lower if their mother have ever used any contraception as compared to children whose mother have never used any contraception. And I also want to highlight that this individual level benefits of family planning is above and beyond the control of family size and spacing, which to me denotes some social benefits beyond the biological benefits that contraception exert its health influences. And above and beyond these individual level benefits of contraceptive access, I did find this spillover of contraceptive benefits. That is, as contraceptive prevalence increases by 1%, children's odds of wasting decrease by 0.7%. To visually present my finding, so I plot out these predicted probabilities of child wasting across the observed spectrum of contraceptive prevalence, roughly from 0% to 90%. So across this range, if you're looking at the right hand, the 90% contraceptive prevalence, children's risk probability of wasting is at least 50% lower than a child who were to live in a context virtually no women have any means to control for their fertility, which is not a small effect size. And the rest of the slides, I did a set of robust checks to really make sure that this spillover is robust. So I asked this first one question, like, is the spillover universal? That is, does it differ by mother's uptake of contraception? Although I already controlled this in the main model. That is, I plot out these predicted probabilities of child wasting across the spectrum of contraceptive contexts by whether their mother have ever used any contraception. And I found that these decreasing effect, like, forgive my causal language, is not distinguishable for mothers ever use any contraception or not. That to me denotes this like distal shared mechanism that favoring all children, regardless of whether their mother have ever used any contraception. And second, I also asked whether type of methods matter or timing of use matter. So basically, I leveraged this like retrospective 5-year contraceptive calendar data to really tease out whether modern methods matter or whether female-led methods matter, like by excluding male condom, male sterilization, etc., or timing, whether it matters only used in the last 5 years. But no, like nothing here really shift my spillover results or the individual level benefits of family planning. And lastly, of course, when I theorize that contraception is this unique dimension of women's empowerment, many of you might have known that DHS collects some indicators of women's power, status, decision-making. I check out this list of autonomy, agency, empowerment measures, but the contraceptive benefits I observe here in the visual and contextual level is not mediated by any of these widely used measures of women empowerment appear in DHS, which to me denotes that contraception has this distinct meaning that they might translate to women's control over certain resources that are beneficial for child health, but that are not captured by DHS. So overall, to summarize, I found that the sample of African children are living in very diverse contraceptive contexts, and the individual's practice of family planning corresponds with these broader population health benefits among the next generation. And these benefits of contraception at both levels likely denote this distinct dimension of women empowerment. And lastly, acknowledge my dissertation committee and my funding agency. I also want to, I recognize that my findings, of course, are not generalizable to many of the presentations today featuring South Asia research. But what I really want to emphasize is that children are living in very diverse contraceptive contexts. Even in early data analysis, I found that within India, just within the country itself, the spatial disparities in terms of contraceptive access have the same substantial wide range. However, we know little about the social consequences of such disparities. So, yeah, that's all of my presentation. Thank you.
Thank you, Yingyi, for that wonderful presentation. I think you covered the two research questions that you asked very well. I'll open the floor for maybe one or two questions, if there are any, on Yingyi's wonderful presentation. No questions? Great, Yingyi. You seem to have won the floor. All right, so you can come up. As you said, moving from sub-Saharan Africa to Nepal, I would like to now invite Dr. Mahesh Puri, who is the co-director of the Center for Research and on Environmental Health and Population Activities, or CRIPA, a national research organization in Nepal. So I ask you all to take this long flight from sub-Saharan Africa to Nepal, and we'll be spending the rest of the session in Asia. Dr. Mahesh has a master's from the London School of Hygiene and Tropical Medicine and a PhD in demography from the University of Southampton, UK. He has been actively involved in SRH research in Nepal for over 20 years. He will be presenting today on integrating postpartum IUD counseling and insertion into routine maternity care in Nepal. So over to you, Dr. Mahesh.
Thank you so much, Priya. Good afternoon, everyone. So I will be talking today about a stepwise randomized control trial that actually aimed to integrate family planning, counseling, and insertion into routine maternity care in Nepal. To give you a little bit kind of context about Nepal, many of you may know already, but I'll just put you in the context. Despite government's efforts and many other stakeholders' efforts, the prevalence of modern contraceptive among married women in Nepal is stagnant since the last 10 years. It is now 43% since the last 10 years, no change at all. And we have a high unmet need of family planning, about 24%. Contraceptive method mix is still dominated by female sterilizations, despite safe, cost-effective, and efficient, and then also Ministry of Health and Population's kind of effort to have a balance in method mix. IUD is not, use of IUD is very low. It's less than 2%. It's only, last DHS shows only 1.4% women are using IUD. And if you look at the postpartum period, the unmet need for postpartum women is very, very high, 52%. Though the provision of immediate postpartum IUD is critical in meeting women's need for long-term reversible contraceptive methods, Nepal has not integrated these services into routine delivery care until very recently. In 2015, International Federations of Obstetrics and Gynecologists, they have launched an initiative to integrate family planning counseling and then especially focusing on postpartum IUD. They have launched intervention in 6 countries, Nepal, Bangladesh, Sri Lanka, India, and then Tanzania and Kenya. Out of these 6 countries, the rigorous evaluation was conducted in 3 countries, Nepal, Sri Lanka, and Tanzania. So in this evaluation study, University of Harvard, with its Courtney Potter, conducted the evaluation study, and the intervention was done of course, it's led by the FIGO and with partnering with its country partner, which is, Country Obstetric and Gynecology Association in Nepal. Nepal Obstetric Gynecology Association implemented the intervention. So there are some changes during the implementation stage that the major interventions that was implemented by the FIGO in all these 6 countries was first providing women with additional information and counseling on family planning, including postpartum IUD, during antenatal care visits and also during the hospital visits for any regions. And they also had an intervention on training of providers, on counseling women, on postpartum generally in the family planning, and also including immediate postpartum IUD. And they also supplied the equipment, which is basically the Kelly's forceps for the insertion. And of course, they have trained the providers for insertion and the removal and complication management, if there is any. And FIGO, initially the FIGO interventions was for 3 years. So my research question for this particular presentation, because from this evaluation study we have published, at least for the Nepal, at least we have 10 publications already out of this study, but this presentation, I focus on only one research question, which is whether the impact, whatever impact these integrations of interventions is happening, whether that lasts beyond the end of intervention or not. I'm not calling here the word sustainability because there is some design issue. That's why I'm saying lasting effect because of the intervention. So data, as I said, data came from that larger study, which is basically designed to evaluate that intervention. As I said, it was a cluster randomized stepwise trial design. For this study in Nepal, we selected 6 tertiary level hospitals, and they were actually paired in 2 groups, Group 1 and Group 2. The pair was done based on the hospital delivery, socio-demographic characteristics of that area, and then kind of structure and human resource of that particular hospital. So we have 2 groups, one group, Group 1 and Group 2. Group 1 hospital actually had a 3 months of baseline period, and then they started intervention. And the Group 2 hospital has a 9-month baseline period, and then after 9 months, they received the intervention, the same interventions. So as I said, the evaluation study had 18 months of enrollment because we keep on enrolling. The study was conducted between September 2015 to February 2017. We have actually enrolled more than 75,000 women in this study in this period. But for this particular paper, we actually choose 4 critical months to analyze and look at whether they have a longer impact of the intervention or not. So we selected baseline month, which is the September 2015, and middle of the month of the intervention, which is July 16 for Group 1, and then October 2016 for Group 2. And then the third critical point is the end of the evaluation of study enrollment period, which is February 2017. And then we also had one additional month, which is after 15 months after the enrollment period, which is July 2018. So I have a data I'm going to present about data for 4 critical times during the intervention period and after 15 months after the intervention period. So this graph is basically showing the number I'm using here. As I said, more than 75,000 were enrolled, but for this particular analysis, these are the women. We have, like in the baseline, we have about 4,800 women. For the middle of the interventions, in Group 1, we have about 2,200 women. In Group 2, we have about 2,500 women. And end of the enrollment, we have 3,500 women. In July 18, which is after the 15 months after the intervention, end of the enrollment period, we have 4,600 women in our sample. So this is the data I'm analyzing for this particular paper. So what we have looked at, basically, we have to simply look at like a PPID postpartum counseling rate, insertion rate in that 18 months evaluation period, and then also the additional, which is the after, scale down the intervention period, which is 18 months after the intervention period. So, and then we also looked at the kind of monthly IUD counseling and insertion rate trends by hospital group, Group 1 and Group 2. We also looked at, like, as I said, Group 1 has a 3 months period, 3 months baseline. Group 2 has a 9 months intervention, while Group 2 has like 9 months baseline and 3 months intervention. So to assess the longer-term impact of intervention, basically I use chi-square to test the difference in PPID indicators. That's what I'm going to describe later on, at the end of the evaluation study, and then the July 2018 data. So I'm basically comparing 2 periods of data here. So to look at and briefly, the socio-demographic characteristics, if you can see the age distribution and parity distribution. This is basically in 2 groups, there is no major differences. Broadly, it's similar you can see in baseline period to July 2018 period. There is no difference in the characteristics. But mainly in age group 20 to 24 age groups have the higher proportions of women. Parity, most of the women has at least 1 children. So again, there is no major difference between baseline and line in group 1 and group 2. In terms of level of education and ethnicity, again, no major difference, but there is a slightly, secondary level of higher, secondary level education predominates the women in our sample, and also ethnicity, Brahmin ethnicity and Janjati were in the majority, but again, no major difference by group of hospitals and also the study period. Now let's look at what is happening and counseling. So you can see in this graph, the first graph is showing the proportions of the women who received family planning counseling, any family planning counseling. So you can see a kind of increasing trend. In baseline, it's about 11% is increasing. Although you can observe the group 2 which is very obvious. Group 2 hospitals has only 30% receive family planning counseling, but it's kind of increasing trend. If we look at another graph, which is basically whether they have received, particularly focusing on postpartum IUD or not, you can see the kind of trend. It was very low during the baseline period, and it's kind of increasing trend, which is very obvious. It's reached up to the 48%, even after the intervention. Percentage, this graph is percentage of women who receive, whether we also act, because they part of the intervention, they distributed leaflet. And then to look at the quality of the counseling, we look at several aspects of in the quality aspect, but I only included 2 indicators here, whether women have received any leaflet during the counseling or not. You can see in the end of the enrollment period, which is the pink color, 71% reported actually they have received the leaflet about family planning during the counseling, but that now, after the July, which is 15 months after the enrollment period, is now starting declining. And also, if you look at another graph, which is basically whether they had an opportunity to ask the question during counseling or not, you can see still, it's not everybody is receiving the counseling, but still, you can see when you compare to a baseline, kind of, the fluctuation, but it remains about, 50%. This graph is basically showing the proportions of women having PPID counseling by month of delivery. You can see by month of delivery, it's more or less, there are a lot of fluctuations over the month, but still it's kind of increasing trend, and then you can see it's remain more or less in the kind of same level even after the enrollment period, which is July 2018 data, which I indicated in the dot, green and red, in for group 1 and group 2, is remained more or less same, but there is a lot of kind of fluctuation by month. This is the percentage, this graph is showing percentage of inserting PPID among all women versus those who receive the counseling. You can see, which is also expected results, those who received the PPID counseling actually have a higher percentage of accepting or inserting postpartum IUD. And you can also observe in this graph, like if you look at the group 1 hospital in 2016 data, about 15% has accepted actually, inserted PPID. That's more or less is higher, like a 6.7, 9.6, and then even in July 2018 is 6.9, which is higher than the average, higher than the report in the DSS. But you can see some kind of a declining trend, so it's not reaches in the like a first. When they started interventions, we reached up to the 15%, and then it's still high, but not that to that level during the first part of the interventions. I looked at the same things by month of delivery. You can see again, it's a similar kind of fluctuations over the month. Is still high, after the enrollment period, which is July 18. You can see the red dot, which is red, and I have red and green there. You can see the green dot in 2018 is still kind of higher, but it's not that high during the active intervention period, right? So it's kind of decreasing trend in the later part of the intervention. So this is it's kind of same what is showing proportion of women having a PPID inserted among counseling and PPID. You can see it's the same graph, but I only looked at those who received the counseling. You can see the percentage is higher compared to those who have not received the counseling. If you look at the percentage, those who received the PPID counseling, especially focusing on PPID, the insertion rate is higher. But again, you see a lot of fluctuation over the month here as well. So in conclusion, what I can say is the PPID interventions in Nepal increased PPID counseling and PPID insertion rate, especially among those who had received PPID counseling, but varied by hospital group, varied by hospital group 1 and group 2. PPID counseling rates were shown to increase after the study period, though the PPID insertion rates were mostly falling during the later part of the interventions. Therefore, our findings suggest that the intervention effects were not completely maintained over time. Duration of intervention between two groups of hospitals and other factors may have played a role in reducing the impact of the interventions. In conclusion, if we put this in the place context, in other countries' evidence, we can say that the impact and the longer-term effects of the intervention could be potentially enhanced by expanding the counseling services, postpartum family planning counseling, and also providing refresher training to the providers. And then I think the intervention period should be longer to improve the sustained effect, because the group 2 has a certain shorter intervention compared to group 1. That's why you see group 1 has a higher kind of incidence rate compared to group 2 hospitals. So that's because of the kind of length of intervention they had in that particular hospital. So in determining to have longer-term effectiveness and sustainability of the intervention beyond the implementation, I think we need even a longer period of follow-up, because we only conducted the study after 18 months, and then some kind of intervention was still going on at that time. So I think we need a longer period of data to really assess the sustainability of the intervention. Thank you so much.
Thank you so much, Dr. Mahesh, for that wonderful presentation. I think you're right, longer-term family planning counseling may in fact be needed. I'll open the floor for questions. Please come to the center, introduce yourself, and you may ask your question.
Thank you so much for the great presentation. My name is Sarah Larabi. I work for Save the Children, and we're actually working on an integration project in Bangladesh and Tanzania with very similar approaches, and one of our approaches in Bangladesh has to do with PPID, and we did train providers for it. And I was wondering, in your testing, what we found is that the rate of counseling is very low, similar to what you presented, and one of it has to do with some social norms and some misconceptions among providers themselves. It's not about the capacity to do the counseling, it's they're not comfortable with it, and they haven't been asked about the misconceptions they have so that they can be addressed. So I'm wondering if there is perhaps some qualitative work that can be done there to understand the problems with coverage. And just to follow up on that, have you looked also about breakdown by age? I'm wondering if they think PPID is suitable for some kinds of women, so multiparas or older women, versus not wanting it for younger first-time mothers, which is the group I work with. Thank you so much.
Over to you, sir. Should we take one more question? Please, go ahead.
Hi, Mahesh. I couldn't resist asking, do you think that the fluctuation you see and the limited impact may have something to do simply with women's choice and the extent to which the counseling is actually messing up their original choice, whatever that might have been. And as a result, you're seeing this temporary fluctuation followed by perhaps no effect. And the conclusion of that would be, let's look at what women's decision-making and agency in contraceptive choices.
Ma'am, could you please introduce yourself as well briefly?
Sorry, I'm Shireen Jijiboy.
One last question, and then maybe so you can answer all of them.
Thank you so much. I'm Margaret Noor, Dr. Margaret Noor from IntraHealth International. So I have one question to the Nepal presentation. It was very, very interesting. We are doing something similar, and we found the same decrease after a period of intervention. So my question is, did you search why this was decreasing after a period of intervention? As you know, behavior change for providers need an accompaniment through mentoring for at least 1 or 2 years of period before it becomes a routine behavior, you know. So did you include mentoring, something like that, to accompany the providers to maintain this behavior for in the time? So this is my question, because you had the same the same observation, but when we included mentoring and continue coaching the providers, the trend came back and they maintained the level. Thank you so much.
Okay, thank you very much for your wonderful questions. For the first questions, whether there is a kind of misperceptions among the providers or not, I don't think that's the case in Nepal, because first the Gynecology Society of Nepal was responsible for implementing the intervention. They have a very good kind of network with the providers, not only with the gynecologists, but also with these nurses. So, I mean, and then they have this standard training package as well. You know, if you have any kind of misperception or bias, the provider's bias towards particular methods, or kind of own judgment, I am very much sure that they have addressed that during the training as well. So I don't think that would be the kind of main issue for this kind of fluctuations. Regarding the age, yes, we have looked at that by age, by ethnicity, several variables. If you are interested, actually, I can share that, as I said in my presentation, more than 10 papers has already published looking into these aspects. So we even have a service providers papers. Their views is already published as well. So I can share that with you, and then that will. So we have looked at various factors that might have an effect on uptake or low uptake on postpartum IUD. On Shireen's questions, yes, I totally agree with you. I mean, it should be women's choice, the fluctuations. Although, as I said, the Nepalese Obstetric and Gynecology Association was responsible for implementing the intervention. So they were not particularly only focusing on postpartum IUD during the counseling. They actually counsel for all methods. And then maybe before this intervention, maybe there was no immediate postpartum IUD services there. Nobody was trained. That's why they didn't talk about that before the intervention. And during that, they actually included that component as a kind of, whatever the package of family planning counseling they had. And they didn't, I mean, in Nepal, as I said, they didn't have the services integrated into the routine maternal healthcare system. They integrated that one, and then, of course, they started all the methods, and then including postpartum IUD. That's why, so choice was there, but I do agree with you that some Asia researchers, there's some level of, I won't say coercion, but some kind of push women may feel, because it's a part of the intervention, and then they wanted to, like, providers were trained, and only after a certain number of insertion, they're supposed to get the certificates, for training completion. So that might have some effect on the kind of fluctuation, maybe a little bit higher immediately after the training, and then goes down. So that is possible, but I totally agree with you, as this is women's choice and women can decide. And it was not that much of kind of pressure given to a particular methods during that intervention. About the questions from Margaret, why reductions? Do we have a mentorship? I mean, I don't see anybody from obstetric and gynecologist association here. They are responsible for actually implementing the intervention. Our role was just to evaluate. But as far as I know, there was a kind of active mentorship during the intervention period. But once the intervention is scaled down or ended, the FICO intervention, I think in paper, to be very frank with you, during the intervention, there was a kind of active mentorship and support systems. They have even mentor built in within that particular the facility as tertiary hospital. But after the phase out, in paper it's still there, but in practice that may be lacking. That's why that's one of the reasons. But the major reasons of this fluctuation and then going the kind of reductions after the intervention, I think, is because of the coverage of the counseling and then quality of the counseling, I think. That's the main issue. We had another paper where we looked at actually, the intent to treat analysis we did, where we have, after controlling everything, only receiving counseling can increase 17 percentage points uptake in contraceptive use. So from the same study. So I think it's majority things to do with the counseling, the coverage of the counseling, and the quality of the counseling. That's the major factor playing a role in this reduction. Thank you.
Thank you so much, Dr. Mahesh. I think you're right. Coverage and quality of services both should be equally highlighted, and I hope that's the key takeaway from the session, from your presentation today. I'd like to now move from Nepal to India and invite Dr. Rajiv Acharya, who's a senior associate with the Population Council and co-leads the SRHR portfolio for the council. He will be presenting on benefits of improved family planning programming on maternal and child health outcomes in India. Over to you.
Thank you. Thank you, Priya. Sorry, I have a very bad cold. And the two first authors are actually sitting here, and they can ask, you can ask questions and they can respond also. So, in the vision for FP 2020 and then subsequently that we are talking about FP 2030, well, the vision is not still fixed, but Government of India strategically converts the family planning program into reproductive, child health, newborn, and the RMNCH program that we have in India. And using that life cycle approach that RMNCH platform engages the cadre of community health workers and provides FP services along with the RMNCH services to in facilities by expanding the range of contraceptive choices and reaching out to non-users in the communities. So both in the facility and in the community. If you look at the recent literature that theorizes that FP program could help achieving sustainable development goals, including improvement in the maternal and child health, as it gives greater control over the pregnancy. So these are the reasons that we think why FP has an effect on MNCH, that gives greater control to the women over pregnancies, allow them to exercise reproductive preferences, attain higher education and participation in the workforce, exercise self-care, and finally rearing children. And all these can actually bring improvements in maternal and child health outcomes. So our research question for today's paper will be whether or not the improvement in the FP programming actually results into better FP outcome, and what is the relationship between the FP programming and maternal and child health coverage. We are not saying one affects another because there could be a chicken egg problem, could be MNCH can have effect on FP, FP can have effect on MNCH. So we are just going to see the relationship between these two. So here's a study design. It's a ecological study based on the district level data points that we have from National Family Health Survey that was held in 2015-16 and subsequently in 2019-21. And these are the indicators that are part of FP programming: unmet need, health worker outreach, information on side effects, and then what are the FP outcomes we look at? Use of any modern contraceptive method or reversible contraceptive method, reversible modern contraceptive method. To look at the MNCH program coverage, we have 4+ ANC, PNC of mother and children within the 48 hours of delivery, first dose of measles vaccination, and 3 doses of penta or hepatitis B and full vaccination. These are 5, 6 indicators we have. How do we do that? We first, there were change the number of districts in the whole map. So we matched the 640 districts that were done in 2015-16, mapped into 707 districts that were done in 2019-20. They were reorganized, so that mapping was done first. And then we estimated the change in all the study indicators that we talked about now between this NFHS for 15-16 and 19-21. And the positive value, and the difference was calculated, and the positive value indicates the improvement in the indicator. Then we create ranking of districts by calculating district score, by generating composite index separately for FP programming, FP program coverage, and MNCH program coverage. This is how we calculate it using the HDI formula, the formula that is used for calculating Human Development Index for positive and negative indicators, and then composite index is calculated this way. It's a sum of all these and divided by total number of indicators. This is the first findings, the categorization of districts by intensity of FP programming. You can see in 2015-16 to 2019-20, FP programming, change in FP programming was low in 236 districts, low with the mean score of 0.235. 236 districts were in the middle, and then high change was in 235 districts. The high ones are actually in green, blue. This is the FP programming effect on the FP outcomes, which seems to be very obvious, but it's an ecological analysis. So you can see among the low change districts, you can see the intensity change in the MCPR is only 2.3%, and change in the reversible method is only 3.6%. But there was a positive change for all 3 groups of districts. The highest change was where the programming was changed most. That means where the change is in the programming was higher, the change in outcome was also higher in those districts. Here we look at the relationship between FP programming and MNCH program coverage. Again, we see wherever there's a significant difference between the categories of districts for all MNCH program coverage indicators and the FP programming indicators. And if you look at low versus middle versus high, and you can see that higher the change in the FP programming, MNCH program indicators were also higher, change in the higher program indicators for MNCH. So there is a positive relationship between these two. The direction of the relationship is of course not possible to estimate here, but this is the relationship. We changed a bit to also look at the unit level data, and we find a very similar relationship in the at the individual level for only the 1921 DHS for the MNCH indicators. So what does it say? It does, of course, show that there is a strong relationship between FP programming and MCH programming, and the integration would only help each other. This study demonstrates the importance of the life cycle approach of integrating, which ministry has taken now. India's that RMNCH program that we talked about included FP as the first pillar of the RMNCH strategy. And the FP programming works as a gateway to encourage women for adopting healthy behaviors throughout their reproductive life cycle, before the first birth, during pregnancy, childbirth, postnatal period, and between the two births, and of course also after completing their desired family size. That's a contribution of this study. Thank you.
Thank you, Dr. Raji, for not only an excellent presentation, but also keeping time. I'd like to open the floor for questions. So, do you want to ask a question? Yeah, of course. I have a question too.
Thank you. Thank you for the presentation. I just have this one question. I guess that everyone might ask you when it comes to ecological analysis and this district level analysis. But I understand that you're looking at is it bivariate association? Like when you do those trending plots, I don't know whether the future plan of this project is also to see whether those increasing trends in contraceptive use and also better maternal and child health outcomes might be a spurious result of the same time when India from 2015 to 2019 economic development is also increasing, women's education is also increasing. I just feel like people might ask, how can you be sure that that's the results of family planning program, the increasing intensity of family planning programs at the same time?
Of the family planning outcome, you're saying? For the maternal and child health indicators, we are not saying it's effect of one on another, it's a relationship. So in the areas where there is a better, there's an improvement in the family planning program, we also see a greater improvement in the maternal health indicators, coverage indicators, I would say. So it's a relationship, it's not effect on one on another.
Great question, Ying. I think I have a similar follow-up question. Did you also look at different wealth quintiles, education, and the impact of that?
This is an ecological study, so it's the district as a unit of analysis, not women, and that's why
That's why you divided into 3 categories. Great. All right. Yes. You can add from there. So, you can come here.
So if you see the map that Raji presented, so you can see there is no really a geographical pattern for the low, medium, high. And if generally the economic development and those things, that doesn't follow, because mostly that follows the state boundaries and all things. So what happens that you can see that in those districts which were very low in the developmental indicators, the family planning programming were more intensive in those districts as well. So that is why it's a nice thing when the next level of analysis we can include those indicators as a development indicators and the program indicators and see what is change is happening. Thank you.
I found it really interesting in the
Maybe
map.
the mic.
I found it really interesting in the map when you show the intensity of family programs by that 600 districts. It's pretty random. It's not
Yes.
like those clustering. Yeah.
That is why.
Thank you.
Thank you.
I think
I'm Arupendra Mojumdar, and with me Abhishek is the first 2 authors. Thank you.
Thank you so much. And I think maybe we can offer one point of integration with the Niti Aayog Aspirational District Program. And maybe that could also be something that we could explore more because they are interlinked and these are this kind of research will be valuable to Government of India, I think, in terms of future programming from 2020 to 2030. All right, so with that, we now move to our final paper for the session. I'd like to invite Mr. Heather, an assistant scientist working in ICDDRB, Bangladesh. He has a master's in applied statistics and a master's in public health. He primarily studies demography and the public health of Bangladesh. His work broadly includes reproductive, maternal, child, and adolescent health and well-being, and measures improvement of demographic indicators. He will be presenting now on postpartum family planning, acceptance in Bangladesh, a longitudinal study. Over to you.
Good afternoon. Today I am presenting a study that we have been working on examining the trends in postpartum family planning use in Bangladesh. And for this study, we used demographic and health survey calendar data. First, some background. As I expect, many of you know, birth spacing is important for maternal and child health. The World Health Organization recommends waiting for at least 24 months after the birth of a child before trying to conceive again. Immediate postpartum family planning is considered a high-impact family planning practice and an essential component of childbirth care. Consistent with this global guidance, the Ministry of Health and Family Welfare in Bangladesh has several policy directives relevant to postpartum family planning. And for example, there are specific guidelines and policy directives for postpartum family planning during delivery care. And in recent years, many children are born to private health facilities. Due to this new scenario, the government has also specific policy directives for postpartum family planning during delivery, after delivery, for the private health facilities. However, there are challenges relevant to this postpartum family planning provision in this country. For example, according to Bangladesh Demographic and Health Survey 2017, among the children of second and higher order, 25% are born within the 36 months of postpartum, I mean 6 months of the last birth. And this scenario makes this makes the scenario pretty complicated, as postpartum family planning is not as expected as in Bangladesh. However, how the trend in postpartum family planning is going in Bangladesh is not examined so far. In this paper, the general research question is how have the dynamics of postpartum family planning use evolved in Bangladesh from 1993 to 2017. The specific research questions are how soon after a live birth do women start using contraception, and what methods do they initiate at different durations of postpartum? How have those behaviors changed from 1993 to 2017? The next specific question is, how is the timing of postpartum contraceptive initiation related to the resumption of menstruation? And how has that changed over time? And the last question is, what factors are associated with earlier initiation of postpartum family planning? For this study, we used data from 8 demographic and health survey conducted in Bangladesh during the period of 1993 to 2017. For the outcome variable, the postpartum family planning, we used the calendar data, as I said earlier, and we linked the health and demographic data from other sections to the calendar data section. And after linking this, we applied single and multiple decrement life tables and also multi-state life tables to examine transition in contracepting and amenorrhea status in the first 12 months of postpartum. And finally, we applied a proportional hazards model to examine the determinants of initiation of postpartum family planning. Here, we see the cumulative probability of initiating contraceptive use over the first 12 months postpartum from 1993 to 2017. There is a clear picture that the postpartum family planning increased over time, which was 32% in 1993, and now in 2017 it increased to 74%. The postpartum family planning acceptance, it particularly increased up to the fourth months of postpartum. Then it continues the increase continues the increase slowly, and it continues up to the last month, I mean the entire postpartum period. Here we see the trend in probability of adopting a method by 12 months postpartum. By first method, the woman adopted. This graph also shows the trend that the postpartum family planning increased over time from 1993 to 2017. And in the method mix, we see that in the increase, oral contraceptive pill is the main driver. It contributed the most, and next injectable was the other method that contributed the most. During the period also use of condom increased, but the most effective methods, long-acting and permanent methods, that did not change. That is close to 3% over the time. In some years that was below 2%. In this slide, we focus only on 2017 DHS data to explore how use of specific methods varies over the first 12 months postpartum. We are using a multi-state life table here. So rather than focusing only on the first method adopting, we look at the method used in each month postpartum. In this picture, we see that the adoption of postpartum increased over the entire postpartum period, entire 12 months of postpartum period. And it like the previous slides, here we see the same picture, that it increases sharply up to the first 4 months of the postpartum period. Then it continues to the entire postpartum period, entire 12 months of postpartum period. And in that contraceptive acceptance, again, pill is the dominant method, and over the postpartum period, injectable also increased. Condom use increased up to the fourth month, then it continued at the same level. Very few women got pregnant during the first year of the childbirth. As the risk of early conception following a birth is influenced by both whether or not the woman initiate contraceptive use and whether or not she has resumed menstruating, which is in turn influenced by her breastfeeding behavior. Here we examine the trends in the median duration of amenorrhea and also the median duration of months before initiating a family planning method. We see that the median duration of amenorrhea decreased in Bangladesh during the study period, 1993 to 2017. During the time, also the median time before accepting a family planning method also decreased. That means the postpartum amenorrhea decreased, which was also substituted by family planning. We also explored the relationship between family planning use and the resumption of menstruation further in this analysis. This slide shows that the probability of either initiating of family planning or resuming menstruation by 12 months postpartum, by which came first. And here you see 3 groups. Women are divided into 3 groups: men's before family planning and men's in the same month, and family planning before menses. We see that the men's before family planning, this portion increased over time. the same message here, the family planning method substituted the menses, resumption of menses. And there is a small portion of women who started family planning on the month they returned the menstruation, and this increase particularly is seen after 2011. And over time, using family planning method before menses increased, and now this has a clear indication that this is increasing over time. Here we focus on the 2070 data again to explore how amenorrhea and contraceptive use status jointly evolve over the first 12 months postpartum. This analysis uses a multi-state life table, so incorporates any discontinuation of contraceptive use in the first 12 months. The chart clearly shows the substitution of contraceptive use of postpartum amenorrhea over the first 12 months following the birth. Here we see the green area, postpartum amenorrhea and not using family planning. This declined over time. At the same time, the not amenorrheic and using family planning, this increased. And amenorrheic and using family planning, this is a small portion. This is remaining pretty similar over time. But the other part, not amenorrheic and not using postpartum family planning, this is around 20%. And this portion is at risk of early pregnancy and immediate pregnancy after delivering a child. Now, turning to the results of Cox proportional hazards model, the probability of adopting family planning postpartum family planning is significantly higher following births that received antenatal care among births. So here we controlled this maternal care, antenatal care services, whether the woman received antenatal care or not, and also there are how many antenatal care visits they received, and other demographic and socioeconomic variables also controlled here. And we find that who received at least one antenatal care visits, among them initiating postpartum family planning early is higher compared to the other women who did not receive antenatal care. But I note that only 8% of the women in Bangladesh actually don't receive any antenatal care visits. And for other maternity care, we see that the women who delivered at facility had a higher chance of initiating postpartum family planning earlier compared to others. Here, okay. The other determinants of postpartum family planning are women under age 20, women with children who had with two or more children, and after the birth of a female child, women with higher education, wealthier women, urban women, and Muslim women. And finally, women in the western and central regions of the country has a higher chance of initiating contraceptives within the first 12 months of postpartum. To conclude, postpartum family planning has increased substantially since 1993-94. Increased postpartum family planning has substituted for declines in postpartum amenorrhea that would otherwise have led to shorter birth intervals. And few women become pregnant in the first 12 months of postpartum. Nevertheless, the majority of women resume menstruating before they initiate contraceptive use. 20 to 30% women are exposed to the risk of pregnancy in each month in the first 12 months of delivery. And as I noted at the start of the presentation, the postpartum family planning high impact practice focuses on immediate postpartum family planning use. Policies and programs in Bangladesh have also often focused on the immediate adoption of IUDs and tubal ligation at the time of delivery. However, our analysis shows that few women adopt family planning at the time of delivery, and the majority of family planning, postpartum family planning use is of short-acting methods, particularly oral contraceptive pills. Postpartum uptake of long-acting reversible contraceptives and permanent methods is very low and is not increasing. This mirrors the larger method mix in Bangladesh, which is dominated by oral contraceptive pills, and very few women use long-acting reversible contraceptives and permanent methods. Yes, we found that considerable progress happened in Bangladesh in using or initiating postpartum family planning. Still, we have some recommendations that we need increased communication on the importance of adopting a contraceptive method before menstruation resumes. Otherwise, they are at risk, and they have to have the knowledge for a short-spaced birth, what kind of dangers are there. And we have to strengthen integration of family planning into delivery care in both public and private sectors. Particularly, we should give extra emphasis in the private sectors, because the number of deliveries and proportion of deliveries also increasing in private sectors over time. And finally, improved communication and service delivery for long-acting reversible contraceptives is important. Despite several efforts over time to improve the readiness and access to the long-acting reversible contraceptives and permanent methods, this is not increasing in the country. So that is another intervention point we need to focus there. Thank you. I presented on behalf of Dr. Mizanur Rahman, and here the senior author of the paper, Professor Sean Curtis, also present. He can also clarify if there is any question beside me. Thank you.
All right, so thank you, Mr. Heather, for that wonderful presentation. You open the floor for questions. We have Save the Children Bangladesh once again.
Yes. Sorry. Thank you so much. This was really helpful and interesting presentation of the data. What struck me was the amenorrhea, the median amenorrhea declining that much. I can imagine this is related to cesarean sections and reduction exclusive breastfeeding, perhaps. I'm not sure if you have looked at that analysis. And the other point is LARC is a chronic problem, like you presented, the lower rates of LARC in Bangladesh. Are you seeing shifts in discontinuation as well for short-term methods, or is this improving? Because we know that there have been strides in terms of family planning. So is the rate of discontinuation decreasing over time? Thank you so much.
Sean, go ahead.
Any other questions?
Okay.
Oh.
Please. We noticed that the postpartum amenorrhea declined over time. In this study, we did not examine anything related to this, but the one point you have mentioned, the increased breastfeeding, that may have affected. And the other thing is the improved nutritional status of women. That can be other sources of this decline. But at this point, we cannot conclude which contributed to this decline. And regarding the LAR CPM and permanent methods, Sean.
I got my question. So I'm Sean Curtis from the University of North Carolina. So your question was about the discontinuation. I don't actually recall now. I mean, the DHS does collect data on that, so I'm not. I don't recall off the top of my head whether that's been changing very much. Usually, the discontinuations rates don't change very fast over time, so I wouldn't expect it to be changing very much. The multi-state life table analysis that Moin and Nafi did does allow. So if they did stop, for the multiple decrement life tables, we're only looking at first event, but the multi-state life tables, we're looking at if they did stop, that's captured they would go out in the multi-state life tables because there you allow them to go in and out. So some of the discontinuation in a couple of the analyses where we just looked at the 2017 data do account for discontinuation. Yeah, and I think on the breastfeeding, we didn't look at that directly, and we did get asked about that, well, because actually I think exclusive breastfeeding's actually been going up a little bit, but still there's issues around intensity, so it's not a perfect relationship. So at least in the data, it's showing a very clear decline in the postpartum amenorrhea and this sort of substitution effect coming in.
Thank you for that wonderful answer. Any other questions? Burning comments? None. So with that, I'd like to conclude the session. Thank you to our wonderful presenters, Yingi, Dr. Mahesh, Dr. Rajiv, Mr. Heather, for your excellent presentations on ways in which family planning can improve child health, focusing on quality and quality and equity as well as choice in addition to coverage, looking at family planning as a gateway of integrating with MCH services to improve outcome, and of course, focusing on communications and focusing on other methods as well. So have a good rest of the day, and thank you all for joining us.